we are very pleased to welcome Professor Iveta Nagyova from Košice, University of Košice, old faculty of medicine. She's also president of European Public Health Association. So it's a great pleasure to welcome you. We will have about 20 or 30 minutes, and after we can have a discussion. Please welcome Professor Iveta Nagyova.
Bonjour. Good morning, ladies and gentlemen, dear colleagues. It's my great pleasure to be here today with you. And thank you very much, Gregory, for the kind invitation. And congratulations with the Congress, because I heard that we were expecting 200 people and there are 600 people present. So I would say that the time is right. Thank you. So the time is right to discuss about non-pharmacological interventions. And today, I would like to talk to you about the state of play of NPIs and public health in Europe. So let's start with the content, what I'm going to tackle today. I'm going to discuss about 4 areas. First of all, I would like to introduce you the European Public Health Association, so that you know who we are, what we are doing, if in case that you are interested for further collaboration. Secondly, I would like to put NPIs into the public health context, and especially to the context of NCDs, non-communicable diseases, which is one of the greatest public health challenges currently. Then I would like to say why NPIs, or behavioral and cultural insights, are a solution, or could be one of the solutions for the problem. And what should be done, the next steps. So I would like to talk to you also about the knowledge translation. Why is it important? So let's start with the EUFA. EUFA is the umbrella organization for national public health associations and institutes in Europe. It was established in 1992. It's a network of over 40,000 public health professionals. And we have currently 83 members from 47 countries of the European region, of the WHO European region. We also have a network of young public health professionals, which encompasses currently together over 4,000 young public health professionals. Our members, sorry, I just forgot to say, are national public health associations, but also institutes. The European Public Health Association is the go-to organization for independent and evidence-based public health information. What we are providing is tailored evidence for policymakers and citizens, contributing to informed decision-making. And our strategy, our vision is to facilitate and activate a strong voice of public health in Europe through analysis of the evidence, then advocacy. That means to get the message across, and action, to capacity building. Our aim, our plan is this AAA plan. So we want to be AAA perfectly in Europe. The tools of the EUFA are the European Public Health Conference, which brings together over 2,500 participants each year. This year, we are going to have a record number of over 3,000 participants, so we already had to close the registration. It will be in Lisbon. And I know that there are some medical conferences which are bigger in size, but this one is one of the biggest with regard to the content. We have 16 parallel sessions and 11 tracks at the same time, so really a lot of very rich program. Another tool that EUFA is using is the European Journal of Public Health, which is a high impact factor journal. It is Q1 or Q2 journal. And another tool is the European Public Health Week, and I just would like to introduce you a little bit more the European Public Health Week. So what we are doing is we are celebrating the public health in 1 week. Usually it is in May. Our main partners are WHO Europe and the European Commission, and each day is dedicated to a different public health topic, and each year we are changing it. This year, one of the main topics was policy making, whether policy is still relevant for public health and so on. And this was the high-level panel. As you can see, we had very distinguished speakers. We had Sandra Galina, Hans Kluge, we had Agnes Buzan, I think I don't have to introduce her to you, we have Sandra Cerdas, and we also had Francesca Colombo. And with this, I would like to continue now with the chronic diseases, and which is one of the biggest public health challenges currently. So why it is the challenge? If you look at the pictures, these are most recently available pictures, which are also putting together information about COVID-19. So when we look at the picture, we can see that chronic diseases clearly dominate both the death, the mortality, overall mortality, but also disability-adjusted life years. And despite the fact that we have COVID-19 already in these figures, you can see in blue that chronic conditions are really a major problem, and we have to deal with that. Why do we have such a high increase in chronic conditions? It is due to several factors. First of all, it's population aging. And I'm not going very much into details of this GIF, but you can see how the population aged between 1960 to 2060. And why this is the problem? It is because with the population aging, people live longer, but not necessarily in better health. So at the age of 10 years, we have 10% of the 15 years, we have 10% of the population which suffers from some chronic condition. But at the age of 65, it's already 80% of the population that suffers at least from one chronic condition. Sometimes it's 2, 3, 4, even 8 chronic conditions at the same time. And another problem why we have such a high increase in chronic conditions is the obvious risk factors, unhealthy eating, lack of physical activity, smoking, and alcohol consumption. And these 4 risk factors account for 80% of all NCDs. Interestingly, this concerns not only us, but also our pets. Just guess what is the percentage of obese and overweight dogs? Can you imagine? It's 50 to 70%. A Swedish study found it. Of course, it very much depends on the breed. Whippets have only 3%, but Labradors are 70% of the Labradors are obese in general. And these figures, people who are not adhering to the recommendations about diet, exercise, and so on, these figures are from the UK. And 95% of the population of UK, adult population, is not performing 150 to 30 per 100 minutes rigorous activity per week, as is recommended by the WHO Europe. And I believe that these figures are very much similar also for other European countries. So when we look at the picture, when we look at the risk factors, we can see that biological risk factors such as aging, genetics, behavioral risk factors, also psychological risk factors, anxiety, depression, as we heard yesterday, social risk factors like social isolation, they are all influencing each other, they are exacerbating, and are leading to 1 or 2 or more chronic conditions at the same time. And I really like this figure because it also illustrates not only the risk factors, but also the biological mechanisms. So this is behavioral medicine, that it goes through inflammation, the sympathetic, parasympathetic nervous system, and HPA axis. So when I speak about comorbidities and multimorbidities, for example, one of the very, very common comorbidity or multimorbidity is cardiovascular disease and mental health. There are multi-directional relationships or interactions, and globally, 32% of deaths are due to cardiovascular diseases, and at the same time, 30% of the population is affected by some mental health problems. And what are the interlinks? So, people with positive features, like positive personality features, are more resilient to chronic conditions and have better cardiovascular health. On the other hand, acute chronic conditions impact mental health. Acute cardiovascular conditions can impact also mental health and can worsen mental health. And the presence of both at the same time is worsening the both conditions. And finally, what is also very often happening is that people who has mental health problems are also often stigmatized in the healthcare system. So this is another problem which is very often the case. People with mental health conditions are stigmatized. So we have an increase in non-communicable conditions, non-communicable diseases or chronic diseases, despite all our public health efforts. So we have a steadily increase. And before the COVID-19 pandemic, only 17% of the countries were on track with regard to reaching the SDG aim 3.4. That means to reduce the premature mortality from chronic conditions by 1/3 by 2030. And 23% of the countries were on track with a small acceleration decline. However, the COVID-19 created the situation that all of the countries are off track because of lack of resources and because of lack of access to healthcare systems, which means that countries will have to invest much more money into the healthcare systems in the future if not effective actions are taken. Another problem is the global health workforce. So currently we have only 50% of the countries have requisite health workforce required to deliver healthcare services, which is absolutely crucial for universal health coverage. And what is also interesting that the global health workforce is unevenly and unequally distributed, which means that, for example, US, which suffers from 10% of the global disease burden, has 37% of the global health workforce, whereas African countries, which are suffering 25%, are sharing the global disease burden, have only 3% of the global health workforce. So this is really, really unequal. Therefore, the leading organizations like United Nations, the WHO, the European Commission, OECD, other organizations are very much aware of the situation that we are going to need to invest a lot of money, and therefore countries are trying to prepare and accelerate to some interventions which could be good, all kinds of possibilities, how we can improve the health of the population, what we can do about the prevention. So there will be a fourth high-level meeting on non-communicable diseases in New York in 2025, and really a lot of countries are organizing a lot of meetings regarding that. So what has to happen? In my opinion, and not only my opinion, but also other experts, what has to happen is definitely a paradigm shift. So we have to move towards integrated care. We have to move towards systems which are taking into account also social care, which are taking into account the self-care. And I'm a big fan of the Wagner's model, despite the fact that this is the model from 1980s, still a lot of countries, or the majority of the countries, is not implementing it. But it is such a wise model, because if you want to be efficient and effective in chronic care prevention, what has to happen is, first of all, you have to have a very developed information system, reminders. We can use artificial intelligence, mHealth, eHealth applications, all kinds of things. Then we have to have a decision support. That means evidence-based guidelines, which have to be implemented very quickly as soon as the evidence is available. Then we have system delivery, multidisciplinary teams. So here comes also NPI, psychologists, social workers, and self-management support, which has to be very important aspect of the care for people with chronic conditions. People with chronic conditions are not the same. 70 to 80% of people with chronic conditions can care for themselves quite well, and they require only 10% of the care from medical staff. So sometimes they are just a burden for the system because they are going to the healthcare system for the services which are not even necessary. And only 20 or 10% of the chronic disease population requires really very high quality hospitalized care. But our current healthcare systems are designed around hospitalized care, are designed about specialists, and we need to put more effort and more emphasis on primary care. In Slovakia and Košice, we were part of the Široko Exchange project, and I would like to promote this project because it was a very, very nice project showing what are the 12 dimensions that has to be fulfilled if a country would like to implement this integrated care model. So you can see there is a financial support needs to be, political support needs to be there, capacity building and other things as well. Very, very interesting project. And let me just continue with behavioral risk factors, why they are important, why they are relevant. Most probably I'm preaching to the reconverted or the convinced. Most probably you are all behavioral scientists, but if not, or maybe we can repeat it, or I can just show you what is my idea, why I believe it is such an important thing to work with non-pharmacological interventions or behavioral interventions. First of all, 80% of premature heart attacks and strokes can be prevented. Also, 75% of the type 2 diabetes can be prevented and 40% of the cancers. And this can be all avoided if we change behavior of people, if we try to motivate them to live more healthily. But behavioral factors and NPIs are very relevant not only for prevention, but also for care. One of the major problems of the healthcare systems is treatment adherence. 50% of the patients do not adhere to the medication as they should. And I don't know whether you have a lot of information about pharmacogenetics and how it works. But if the patient just misses 20% of the medication, the effect drops by 80%. So if people are not taking medications, their health status cannot be improved. And also, as I mentioned, the self-management support is another relevant aspect. So why to change behavior is so hard? First of all, it is because knowledge and intention and action, they somehow do not match. There is something what is called intention gap. And behavior change is complicated and complex because it requires a person to disrupt a current habit while simultaneously they have to foster a new and possibly unfamiliar set of actions. And how we can overcome this? Which theories, which psychological theories are explaining why it is so complicated to change the behavior of the people? So first of all, the dual process theory, Thinking Fast and Slow, Daniel Kahneman and Amos Tversky, they discovered it, that people are not rational beings, that people are irrational, but irrational in a predictable way. And we have the so-called dual system. The first one is fast and effortless, and we use this system when we are, for example, driving on the empty road, or when I ask you 2 + 2 = how much, you can immediately tell me that it's 4. And we have another system which is reflective, which is more thoughtful, which is more conscious, which is more slow. And we are using this system when we are, for example, filling in the task form, or when I would like to ask you 17 multiplied by 24, how much is this? We don't know. Again, and people are using different types of shortcuts and heuristics and cognitive biases. And as I said, perhaps I'm telling this to you, but why I'm mentioning particularly this theory is because this theory is currently accepted by the WHO as one of the leading theories. So we have 188 identified cognitive biases and heuristics. There are very interesting biases, very interesting heuristics that people are using. For example, the IKEA effect, perhaps you know that if you put together something yourself, you value it more, or many other things, the friction costs, so people are not motivated to do some behavior with a seemingly small obstacles. So when you have some obstacles, people don't do the behavior. For example, in COVID-19, we've seen it, that if you had to fill in some forms to get vaccinated, people just did not do that because it required a lot of effort. And there are many more examples for nudging, for how it can be used. So I'm not going more into details, but you can use the social norms and feedbacks for, or has been used for lowering the prescription of antibiotics by primary care doctors, or, for example, how to increase the hygiene in hospitals and safety in the patients. Very simple screensaver. So you put the screensaver on the computers in the rooms of medical doctors, and it improves the hygiene, very simple things. And nudging works, but it's not enough. We have to have a little bit more complicated theories as well in place. People get easily bored. So another theory which is currently accepted by the WHO and which is promoted is the COMBI model, Capability, Opportunity, Motivation, by Susan Mickey. And this model says that if you want to change the behavior of the people, 3 conditions have to be fulfilled. First of all, the person has to have a mental and physical capability to change. Another condition is motivation, which can be intrinsic, internal, or external motivation. For example, internal means that you decide yourself to do some behavior, stop smoking, for example. External motivation is that the government raises the taxes for tobacco products and people don't buy it because it's too expensive for them. And the third one is opportunity. So you have to have physical opportunity to perhaps to perform some behavior. So the environment which surrounds you, physical and also social environment, has to be very supportive. And next to behavior change wheel, we have the next to combi model, we have the behavior change wheel, which is also summarizing what are the interventions, what we can do, and what are the policy categories which we can use to change the behavior of the people. So this model, the combi model, was based on the 83 different psychological theories and behavior change techniques. And I really like this so-called behavioral periodic table of behavioral change techniques, which summarizes all the techniques which are available. And I will just show you a couple of examples. So for example, repetition and substitution, make it easy. This is the example of from our study in Slovakia. What we did, we compared effects of Nordic walking with traditional walking in patients with cardiovascular disease. It was a 3-week training, and it was absolutely identical with regard to the time and frequency of exercise. The only difference was that one group did Nordic walking, another group did traditional walking. And we found, as you can see, that the Nordic walking group was far more efficient. So we just substituted a very simple activity with another one. Sorry. And people are not even aware of that, but they were involving more muscles, also the upper torso, which is different as compared to traditional walking. And it is very good also for the elderly people because it gives them more stability. Another example is from the first category, goals and planning. And this is, for example, the example for behavioral contracts or commitments. So if people are making commitments to do some activity publicly, they are more likely to adhere to the behavior change. This is the example of the app or program called STICK. And people commit themselves to do some physical activity, let's say, or some nutritional change several times a week. And if they don't do that, they commit themselves to put some money for charity or anybody whom they are interested, for friends or for family or whatever. Very interesting program. Another one is antecedents or choice architecture. This is also very relevant within the context of the public health because the way how we design buildings and cities also can help us to improve our healthcare and habits and lifestyle. So in the hotel, for example, I saw a note that not burn electricity, but burn calories. Don't use the elevator, use the stairs. Very, very wise. I think I like it very much. But as I said, we have to really think about designing the cities. Yesterday, we heard a very interesting presentation about brain and neuroplasticity and how the brain works. And I don't have the slide here, but I believe that you understand it as well, that beauty and architecture, beautiful architecture is also very positive for the brain. It releases oxytocin, dopamine, and so on. So there are very fascinating studies from the group called Salutogenic Design and Architecture. So another possibility, what we can do is also feedback and monitoring. And this is also the example of one of our studies in Slovakia, in Košice. It is the Horizon 2020 project, the INSEM project, IMMERSE project. And we are not leading this project, we are just partners. This is a very interesting project. This is for patients for mental health problems or mental disorders. And this project, what it's doing is that it uses the so-called experience sampling methodology. So it is the electronic diary. The patient is filling in several times a day an application, how they feel, what is the context, when their health status worsens. It can be used also for treatment adherence, why people are not taking medications. So very, very interesting study. And why is it interesting and why is it relevant is because there are currently over 300 health apps in the 5 major app stores, but only about a dozen of them are evidence-based. That means the rest is just irrelevant. They are not doing what they are claiming to do. And with many of them, there is also another problem, and it is the problem with the privacy sharing and the data sharing, the GDPR and so on. So we are developing this tool as a medical device, but it's a question whether it should be a medical device because there are some tools which are on the market and are not fulfilling the criteria. So we discussed again with Gregory about it, that what should be done with regard to legislation at the European level. So this is just an example of some other research that we have done in the field of behavioral medicine in Slovakia, and I always was curious. We did it with a small team over the period of 10 years. We are covering approximately 15 chronic conditions, and we have over 8,000 individual records in our database. This is the analysis of the articles published in journals, in impact factor journals. So the word which comes most often from our publications is patients. When I removed it, then it's about quality of life. And when I removed the word quality of life and all the diagnoses like multiple sclerosis, Parkinson's disease, cardiovascular disease, you can see that the topics that we are dealing with most is social support, fatigue, self-esteem, anxiety, depression, so a lot of psychological and social topics. And these publications are quite well cited as well. So the age index is 29, and so we put it together with the group of approximately 20 people. Perhaps it's not so impressive for you, but coming from Central and Eastern European country and doing it from our resources, it's quite an achievement in our countries. And when we were dealing with these chronic conditions over the years, I just realized that a lot of chronic conditions have exactly the same pattern. So people with chronic conditions are suffering from the same problems and are encountering the same problems. So it all starts with pathology, at the molecular level. Then we have the impairment. So the person has some problems with moving. Then there are functional limitations. So a person cannot perform certain activities like comb hair or doing shopping or cleaning the house. And it influences and impacts the quality of life of the patient with a chronic disease, but also its family. And interestingly, there are some factors which can speed up or slow down this process of deterioration, the so-called disablement process. So first of all, the risk factors, biology, gender, age, ethnicity. Secondly, extra individual factors, that means social support, the quality of the healthcare system. Then we have also intra-individual factors, coping resources, resilience, anxiety, depression, different type of factors. And what is even more interesting is that there are feedback loops. So if you are able to improve the quality of life of the person, it goes back. It can improve the functional status of the person. Or, it is like this. Therefore, non-pharmacological interventions to deal with the health status, the mental status of the patient with a chronic disease makes a lot of sense. And so this is the slide, which is kind of like justifying why we should do that, because it works. It works, it's very effective, and we can help patients very much. The final part, which I would like to talk to you about, and by the way, Gregory, congratulations with the registry. It's a fantastic achievement. And Gregory did something what I'm going to talk about now. So it's not enough for us just to be researchers. It's not enough just to do research. It's also important to put research into practice, to bring the results to the real patients. So we have to do knowledge translation. We have to focus on policymakers and also practitioners. And, maybe I can go back. No, it doesn't work. Anyhow, I had this slide, two parallel universes, because the policymakers, scientists are really like living in two different planets. They have very little in common. And sometimes policymakers, but also healthcare professionals or public health professionals are very, self-confident. They know everything. They know that why people are not doing something, And it's just common sense. If you tell people you should eat healthily or you should do some exercise, people will do that, right? It's logical. No, they will not do that. Because as we heard, it's not about getting the message across. It's not about knowledge and information, which doesn't drive behavior. And people act rationally. It's also a misconception. But people also don't act always irrationally, because the irrationality of somebody is the rationality of somebody else. So I don't have time to go more into details, but I highly recommend, again, this publication by Kelly and Barker, which very, very nicely illustrates the so-called arrogancy, sometimes from the policymakers, and what can be done about it, and why we need to talk to policymakers. And when we speak about knowledge translation, there is something what is known the know-do gap. So there is a chasm between what is known and what's get done, the implementation gap. So the science and the scientific advancements are increasing very much steadily, but the way how we are implementing it in the practice, it's lagging behind. So sometimes in medical field, it's 17 years. So it's a 17 years of odyssey. When you start with some research, till the outcomes of the research are implemented in the practice, it takes 17 years. How much is it in non-pharmacological interventions? Do we have any statistics on that? I don't think so. And what is another problem with patients in general, with physical problems? I mean, we are just talking now about medications and care. Only 50% of the patients are currently receiving the recommended care, and 20 to 25% are receiving care which is not needed or is potentially harmful. And again, it is very much relevant within the context of registry and within the context of evidence-based outcomes. There are many people, like Gregory said, charlatans, who are saying, we are doing fantastic behavior change interventions, but they can be potentially very harmful or ineffective. They can get money for that. So it's very, very important to have evidence-based. It's very important to have the registries. So what we can do, how we can collaborate with policymakers. Jeremy Grimshaw did a very nice study which showed that there are only two factors which matter. First of all, interaction with the policymakers. You have to be in contact with them. And the second is that your research has to match the values and programs of the policymakers. And how you can do the interactions, it can be either direct interaction, so you can be a consultant for the policymaker, which is very good on the one hand, because you can have a very good control over the message. You can, you know exactly what you are telling to the policymaker, but it is very time demanding. Sometimes they want you to respond within 1 hour, 24 hours. It happened to me that they wanted me to respond within 15 minutes. I responded in 16 and it was too late. So this is the reality. Then what you can do is also indirect engagement, that you engage with some advocacy groups, for example, or some professional organizations, and you amplify your voice. And finally, engaging the media. So when you are doing a lot of social media or mainstream media, it's also the way, but in that case, your control over the message is smaller, because journalists are very often distorting the message. So you have to choose which way of communication or influencing of policymakers you are choosing. And UFA is quite active in collaboration with policymakers. So these are just some examples. So our main partner is the WHO Europe and the European Commission, obviously. These are just some examples of the advisory boards where I have been present. And again, it should not be like, look how clever I am. It's more really about the possibilities that these organizations are giving you. And the one of the areas where I'm very much proud and I'm very happy that I could contribute it to is the agenda on behavioral and cultural insights, the resolution and the action framework, which was adopted in September 2022 at the RC72 in Tel Aviv. And you probably can't see that, but I'm here. And I was selected from all 53 member states to present the agenda, because I'm also a national focal point for Slovakia. And I'm so glad because as I said in the beginning, the time is right. The time is right with regard to non-pharmacological interventions. It never happened in the past before that the WHO was so open to incorporate some other fields, some other disciplines, to incorporate, knowledge from, as I said, from some other disciplines. So behavioral and cultural insights is now one of the 4 flagship initiatives of the European Programme of Work of the WHO for years 2020-2025. And we heard from Hans Kluge that also for the next period, it will be one of the priorities. And this is also the priority not for the European WHO, but also for the global WHO. And last year, the resolution on behavioral sciences for better health at the 76th World Health Assembly in Geneva was adopted by all 194 countries, which means that the countries committed themselves. It's a political commitment, it's a financial commitment that they will mainstream behavioral sciences, non-pharmacological interventions, nudging, if possible, in all policies, primarily in healthcare, but also in other policies, because all policies are interrelated. We have to improve the transportation, or food and nutrition. Agriculture is also related to a health system. So behavioral and cultural insights have a lot of sense. UFA, we started in small, so we organized only several workshops at the European Public Health Conference. And the first one started with Gregory and Kim Lavoyer and Simon Bacon in 2019. So this was really the first time when this agenda was very systematically introduced in the public health community. And it was a fantastic experience because we had a session Saturday around afternoon, when all people are already gone. They went for the conference, but you can see the room was full of people. So there were a lot of public health experts who were desperate to hear this information, to look for solutions, because we know that what we have done so far in the field of public health did not work. So what are the new solutions? So this is one side of the story. There are people who are very active, very eager, like a sponge. They want to absorb all the knowledge. But also, let's be honest, there are public health experts who are very rigid, resistant, and they say it's irrelevant. It's just an individual approach. So we have to deal with this dualism, so to speak. What are the take-home messages for you from this lecture today? Siloed programs to tackle chronic diseases are increasingly unfit. And we need cost-effective, feasible, and relevant interventions. These are urgently needed if we want to solve the problem. We have to protect the correct investments, and we have to find solutions, because there will be no more money in the system. We will have more people with chronic conditions, more elderly people. So we will have to be very, very innovative how to find solutions. And policymakers will need clear guidance how to incorporate behavioral, cultural insights into the overburdened healthcare systems. I would like to also mention BCI washing, because it's currently the agenda of the WHO. Many people are claiming that they are doing behavioral and cultural insights, or NPIs, as I said, and therefore the registry is very relevant. It has to be evidence-based, it has to be widespread, and we need definitely synergies and innovation in the new era of public health. So what I mean by synergies and innovation? I mean that we very often work in the silos, public health experts, behavioral scientists, social scientists, anthropologists, people who deal with economics. But if we want to be very efficient in the healthcare systems, we have to come together. And then from these individual pieces of mosaic, from these siloed efforts, we can have a very nice mosaic, very nice picture, like, for example, this one in, I forgot where is it, in Rome? And why it makes sense, it is because the whole is always greater than the sum of the parts, as Aristotle said. So thank you very much. This is what I wanted to share with you today, and thanks a lot for the attention.
Thank you very much, Iveta, for this presentation. Maybe you can have a question. You can ask in English or in French. I can translate. So, allez-y, vraiment, on a vraiment un grand plaisir d'avoir professeur.
So do not hesitate. It's our pleasure to welcome Professor Iveta Nagyova here. You can ask your question either in French or in English. Mr. Boyer.
Thank you very much. Est-ce que le micro fonctionne? Oui, c'est bon. Profitez.
Thank you very much, Iveta, for this presentation. I'm Marcel Claquin. I used to work for many organizations, including WHO, with regard to the strengthening of the public health workforce and the HRH in general, human resources for health in general. So when you pointed with that graph that there were very few human resources for health with regard to the burden of disease and also in different parts of the world, I think with the NPIS, I approach a non-pharmacological interventions approach. We can really rely on new type of workforce, the care workforce, and the one that are not necessarily recognized as part of the, the official list of the health workforce. So I think you touch a little bit on it, but can you expand a little bit more? I don't know if in UFA you talked about that, how we can really integrate all those health workers and the care workers. Thank you.
Yes, sure. Thank you very much. It's a very good question and a very good comment, because indeed, in the new modern healthcare systems, we should not have this hierarchical healthcare system, but we should have a patient-centered care system where all the healthcare workforce are bringing together and are collaborating together. So, as you said, we could have, let's say, care coordinators, which do not exist in many countries. We can have nurses who have more competencies. We can have social workers to be part of the team, like in the integrated care models, or new professions. We have new areas. We have AI, digital technologies, mHealth. So we have to learn also how to work with these new technologies. And it doesn't come into my head what can we do, but we can do really a lot of things. And when you ask about the UFA is actually, I did not mention it in the beginning because I thought that I will speak about it a bit later, longer. But UFA is a very unique organization. It is truly a multidisciplinary organization. We have 29 thematic sections on chronic diseases, on mental health, infectious disease control. But we have also very untypical or unusual UFA sections, like, for example, urban public health, where the president of the section is architect. We have people with background in law. We have people in background with ethics. And for example, even myself, I'm not a medical doctor. I'm a psychologist. I'm a clinical psychologist by the training. And I'm the first UFA president not to be a medical doctor with non-medical background. So, definitely, we see it in the UFA, and the ideas which I presented today, we are very much promoting, also within the context of capacity building. So we are helping also our national public health associations to shape a little bit, the health workforce. We have a section, by the way, on public health workforce as well, which is specifically dedicated to the challenges, to the current challenges, at what can be done and how to improve the healthcare delivery systems.
Thank you for the question. Please.
Thank you. I'm Anne Liuto from the NPI Society Scientific Council. I'm very, very struck with your presentation. I thought it was very challenging, very interesting. I'm not a specialist of health systems, so I was having just a clarification question. You talk about this non-communicable disease, and then I wondered what was the relation with the chronic disease that you most of the time referred to, and then within those, the new conditions, like we feel that there are some relationships between them. Can you explain maybe a little further?
Yes. Thank you. Well, I'm using the term interchangeably, and to be honest, I personally don't really like the term non-communicable diseases. But it's the word which is used, or term which is used by the WHO Europe. So therefore, on some slides, I have NCDs, non-communicable diseases, but I personally like more chronic diseases or chronic conditions, because you can have chronic condition even which has infectious beginning, you know, like COVID-19, for example. Now we have a long COVID, but there are also other examples. So I would say that within the context of NPI, it is more relevant to speak about chronic diseases or chronic conditions, because what we have also is something what is called the disability paradox. So it means that sometimes people, despite their chronic condition, chronic disease, can still have a high quality of life. If they can if they can work, if they can participate in the society, if they have good networks. So despite the health conditions, they can still be very happy. So therefore, I would say that maybe even chronic conditions is the better term, how to live with a chronic disease. And I'm happy that sometimes there is a shift in the terminology. So we don't say like chronically ill or a cardiac patient, but we say person living with a certain chronic condition. I think this is more relevant.
Another question, French or English? Madam?
Do not hesitate to introduce yourself before putting your question.
Thank you very much for the presentation. I thought it was very, very interesting. My name is Marika Verheijen. I'm Dutch. We're here with a poster where we did a first project, a pilot in a village over 8 weeks with elderly people over 60 and plus, where we did over 8 weeks, like working with them on breathing consciousness, heart coherence, and then looking at the results, the health results, which were quite amazing. And so we're now looking with the European filing for EU grant to do this in 3 different villages in 3 different countries, actually in Poland, in France, and in Spain. And I'm just fascinating to see your presentation. Would there be an opening to work or to have a partnership or to seek the knowledge that you have within the European Health Association? Because, you know, it's very much this synergy that I believe, and also involving locally the village and the community in really having this on a long term and to really change life patterns.
Absolutely. And most probably you are also aware of the villages for people with Alzheimer's disease in the Netherlands. It was the first village. And I think this is also amazing thing, you know, that to help people with Alzheimer's disease to live still kind of independent and fulfilling life despite of their conditions. I've been at the conference, I think it was in June, most probably, in Milan, at the Politecnico di Milano, and there was exactly the group coming from Salutogenic Design, Alan Dilani and some other people. Also, the president of the UFA section on urban public health is a member of this group. And actually, we are discussing to start a new section on salutogenic design and architecture also within the UFA, because I think this is also not very often used tool in public health. So very often I was struck by the fact that at the schools of architecture this is not taught. So salutogenic design is something what is new also for architects. I would not believe that, you know, but there are several very interesting buildings. For example, the hospital in Groningen. I have a PhD from the University of Groningen, the Martini Hospital. It is an amazing hospital. Please Google it. There are 18 meters tall palm trees in the hospital. There are streets which are called like Fountain Street. There is a real fountain in the hospital. There are bars, and it was there already in 1996. I had really a cultural shock when I saw this type of hospital, and patients were sitting in the bar with IV and with their friends, with their relatives. It was just amazing. So yes, definitely this is one of the priorities, and I'm a big fan of design and architecture myself. So I think this is a really unutilized resource that we have to improve the health of the populations in general.
Question here, please.
Bonjour, Olivier Reynaud, je suis médecin, je suis ici avec une association qui s'appelle Parkinson.
Good morning, I'm Olivier Reynaud. I'm here with an association dealing with Parkinson's disease. I'd like to tell you about an initiative that was really done about high blood pressure in Barbados, just to see if we can cooperate with doctors, nurses. In Barbados, there was a huge problem with high blood pressure, which was not diagnosed, but we could see that many people had strokes. And whenever treatment was offered, patient medical adherence was very slow. And what we did is that we worked with companies, with papers, with professors, and a solution was offered. Today in Barbados, there is no such problem as high blood pressure anymore, because thanks to hairdressers as well, we have been able to diagnose high blood pressure, offer treatment, and ensure medical adherence. And the champion in this is not a cardiologist, but it's someone who managed to really mobilize all the hairdressers in the region to offer things that were really useful for communities. So it's a wonderful initiative that you are presented. You're saying that it's wonderful to give some room for NPIs, but I think that you should also invite some other stakeholders in this room.
Experiment in Barbade, probably, with the community about hypertension, and all the actors, and especially Berber, was very important to... Si vous le faites en anglais... C'est pas que je trouve que c'est bien, mais...
For those of you who don't know the story of hypertension in Barbados, you must look at it. This is a fantastic lesson. This is a way to engage barbershop hairdressers in the prevention, detection, and compliance of treatment for hypertension. So the Ministry of Health of Barbados, who was an economist, by the way, was faced with a huge disease burden of stroke, ischemic cardiac disease. And faced with this issue, he had the plea of people to build a cardiology ward and recruit a cardiac surgeon. And he ended up building an initiative which is engaging with the hairdresser and barbers. Where do the young men go often, and how available for advice and for measuring their blood pressure? Hairdresser. They go there every 2 months. So Google hypertension in Barbados, and you will learn a lot about this initiative. But there are a lot of jewels like this that needs to be replicated. No need for policy making, etc. Need for mechanisms that are allowing to implement the working mechanisms that have worked elsewhere.
Yeah, thank you very much. Thank you very much. I understand. Actually, I believe that we have to use all the tools, you know. So I would say that policy making is also important because it can tackle part of the population. But what you were saying or highlighting or showing is an orthodox, creative approach, and we need more and more of these type of approaches. There are also projects with people in the pharmacies, prevention projects, because people, I mean, people are going very much to the pharmacies to buy some drugs and so on. So healthy people. So this is also a potential for a lot of prevention programs or a lot of information programs for the people or how to tackle them. So very interesting. Thank you very much for drawing our attention to this topic and to the possibility. And I think with Gregory, you will have these kind of interventions in the registry. So I think we need that. We need that. Yes, yes.
Yes, we are. Question? It's probably very important to understand that we have a change in health. Last century, it was maybe the heritage of Claude Bernard, one problem and one solution for health, drug or surgery of. And now, the complexity, as you mentioned, of the health problem needs multi-solution. And so integrated care, it's now a necessity, no, I don't know, to change the way to think health. And you are an expert in health behavioral change and president of a famous organization, but we have in the room Anne Villemain, president of the French Public Health Organization. She's a sport scientist. You talk about an architect previously as a president of UFA. We need to understand, and thank you for your question, we have to have a lot of courage to change the Claude Bernard vision of health with the simplicity. The complexity need multi-solution. So my question is about in the oldest vision of public health, and the practical aspect is dedicated to health promotion, and not enough targeted and personalized intervention, especially for prevention, but also health. What do you think about the balance between the global recommendation, promotion, and targeted?
Very good comment, very good note. And with regard to public health community in general, many national public health professionals or communities are very rigid, and they think that public health is only vaccination and hygiene. Even I heard that even in France it was like that. I hope that it changed in the meantime. But you would not believe it was the same also with the UFA. So I was at my first UFA conference in 2001. So it was the time when I started to be familiar with the UFA. And because of my expertise, because of my research in the field of chronic diseases and chronic conditions, I was asked by the time by the executive director of the UFA, Dineke Ziegers, to establish a section on chronic diseases, chronic conditions. And it was in 2006, and at that time in UFA, there was a lot of resistance. They told me it's not a public health issue, it's not a public health problem. How chronic disease could be a public health problem? We deal only with prevention, like what you said. So, you know, it really took us a lot of effort to convince the old-fashioned public health professionals that this is very relevant, because you need not only prevention, but if people are already sick, if they have some disease, you still can do something about that. You still can improve their health. So, and interestingly, this is happening exactly the same with NPIs, with behavioral and social sciences, exactly the same. You know, when I was elected to be the president-elect of the UFA in 2018, I was thinking, what I can bring, you know. I'm not sure whether some of you are here public health experts, but the previous president was Natasha Azopardi-Muscat, who is now one of the directors, the closest collaborator of Hans Kluge. And before that, it was Martin McKee, who is the synonym for public health. He is writing 100 impact factor publications per year, and he's really contributing to them. So he's crazy. He's really crazy. And I was thinking what I can bring, you know, to the public health community after such high-level experts. So I thought, for me, it makes a lot of sense to bring together behavioral science. In 2018, I was mocked. The public health community told me it's irrelevant. You know, it has nothing to do with public health. I was like, what? There is a solution. But then, fortunately, in 2020, it became one of the 4 flagship initiatives of the WHO Europe, and now everything changed immediately. From one day to another, a lot of people who said that it's irrelevant, they claimed that they are experts in the behavioral and social sciences. So it was very funny. So it's really like, it's very popular now. So everybody is now saying that we are doing behavioral science. This is called BCI washing, like you have greenwashing, you know, when you want to sell the products, you say that it's very ecological, it's green and so on. And now if they want to sell some intervention or something, they say that it is BCI friendly or BCI incorporated. So we have to be very cautious regarding that. At the same time, we have to use the time. we have to use the momentum because this is not forever, you know. So this window of opportunity which we have as social scientists or behavioral scientists to be able to influence the public health policies, we have to use it. Because most probably Hans Kluge will be again the director of the WHO, and Dr. Tedros at the global level is also very open to nudging, to BCI. But if people change, the agenda changes as well. So we have to be very efficient, and therefore I'm coming also to these events, you know, to try to bring together the two communities, to try to motivate you, to invite you to our events, to the public health community, so that there are more and more topics. For example, last year, or it was this year, I don't remember now, I think it was this year, yes. I specifically put as one of the keywords into the UFA submission, abstract submission system, behavioral and cultural insights. And guess what? There were not enough publications submitted. So in the end, we could not create a track. There were just a couple of publications dealing with behavioral insights or behavioral science is relevant for public health. So everything what was there went to health promotion. And when speaking about Anne Wilman, sorry, she's amazing. I don't know whether you know, but she's collaborating very closely also with the WHO Europe. And apart from the things which we mentioned here today, but we tackled or touched upon lightly as well, is systems thinking. And they are having summer school on system thinking. So they are organizing it together with the WHO and Ulysses University. So it's very, very important really to put together all the system elements if we want to change something in the healthcare systems. As I said, agriculture, transportation, different fields, different disciplines. And it sounds very complicated, but Anne and her team, and the summer school is showing how it can be done. And we have to adopt this type of thinking and this type of capacity building for public health experts and also for behavioral scientists. So we have to be humble, because sometimes, you know, people are insecure and they don't want to collaborate with somebody because they are not familiar with the field, or sometimes public health experts think that they can learn it very quickly because nudging is very tempting. Let's say, you know, you read some things and you all of a sudden feel that you are an expert. But you don't have to, as a public health expert, you don't have to be also an expert in behavioral science. It's very important that you collaborate with people who are experts. And I think this is what we also had to put into the minds of people, that we definitely need, you know, humbleness. We definitely need multidisciplinary collaborations, cross-disciplinary collaborations. I really believe also in so-called cross-fertilization. That means that you can adopt some techniques or some ideas from one field and use it in another, just like an inspiration, because you are exposed to that. So it's there are amazing opportunities.
Question? Thank you, Professor Nagyova. I'm Mathis Brier. I'm involved in the NPI Society, focusing on young researchers. I'm an osteopath myself, and I'm starting a PhD, and that was quite hard. And further, universities and researcher workplaces, all of this is more and more competitive. Universities have less and less money to pay all of this. And in the environment of non-pharmacological interventions, there are a lot of professions with a very high heterogeneity. Some of them are not even regulated by law in some countries. And are there, my question is, are there some organizations, maybe UFA or others, that can deal with it to have maybe workplaces or money or things like that to help these interventions to be developed with high quality researches, and to have money for PhD or things like that? Because actually in some professions it's very hard to have a career in research and to even to start a study in Master of Science, even though that's my question. Thank you.
Thank you. Yeah, it's a very complex question. Let's be honest, UFA is not a foundation, so we don't have, you know, a lot of extra money, so to speak. But one of the priorities of the UFA or the visions of the UFA is really to help also low and middle income countries, or to be more precise, countries which are not part of the European Union, but are all part of the WHO European region. That means 53 countries. So as I showed in the beginning, we have partners from 47 countries. We are still missing some countries for Central and Eastern Asia, like former Soviet Union countries. And one of the priorities, and actually even the Slovak Public Health Association was established by UFA, because they had a project. They realized that they were very visionary. They exactly realized that, you know, there are not so many resources in these countries, financial resources, but also capacity. I mean, mental capacity and knowledge and know-how and expertise. So one of the visions and missions of the UFA is really to help these countries. And as I said, the Slovak Public Health Association was established thanks to one project which UFA was supporting. So we have the so-called Joke van der Zee Foundation. When we have extra profit from the conference, we are supporting young public health researchers in countries, sometimes some projects, smaller projects, but we want to develop that more systematically, and it's also one of the priorities of the WHO Europe. So I believe that there will be, you know, there will be kind of like more money or possibilities for support also young public health professionals in these fields as well. But we have to be creative, first of all, and secondly, it has also really a lot to do with knowledge translation and collaboration with policymakers, because also, again, where the money is put in research, it's also the decision of the policymakers. So we did, in UFA, we did a research that how much money goes into the let's say, public health research. It's just 7% of the money. It's from all research funds that were available, which is ridiculous because it's very efficient. So as COVID-19 showed that if you are doing a lot of prevention, you can save a lot of money. €1 invested in prevention is €14 saved in healthcare systems. But still, for some reason, policymakers, decision makers are investing more into biomolecular research and medical research. So I think we have to be more vocal. We have to advocate more for more these type of research, public health, non-pharmacological interventions, because these are low-cost interventions with a great outcome. They can bring a lot of very interesting results. And actually, this is why it is relevant and interesting for the WHO, because they understand that, you know, it doesn't take too much money to develop a certain non-pharmacological intervention, and the effect can be a big change in the health of the populations. So we all have to work on it.
Thank you very much for the answer, and thank you very much for the question. Mathis Brier is the responsible of the young researcher in the NPI. You know that it's very, very difficult to design study and to have financial support for the research, because we have a little bit, I am very old in our career. Research was only for researcher at the university, and patients and professionals did not have to do research, only research for researcher. And the conclusion is the researcher produce only identification of problems, just problems, but without any solutions. And young people here, the building is about the young researcher. We have to change the rules and the habits of research. For example, patient-reported outcomes, just to ask to the patient the intensity of the pain. 20 years ago, it was not possible. We have just to understand the mechanism of pain without thinking solution. So we have to work together, patients, researcher, architect, etc., to push to the politician, and thank you because you are the key person for that, to push the politician to, of course, focused financial support for biomedical research, surgery, sure, but also for NPIs. So thank you very much for, maybe a comment? Sorry.
No, I just wanted to say that also to support more implementation research, because like you said, research, basic research mainly creates questions, but implementation research also is bringing solutions. So our Immerse project is implementation type of research. So we are testing a device in real life medical settings. And interestingly, one more comment regarding that. You know, we are sometimes naive and very optimistic, and we think that, oh, with AI and mHealth and eHealth, the medical doctors will be so happy that they can implement the technologies. It's not true. It's not true. It requires a lot of time, effort. They have to change the way how they work. And it is very difficult to implement these type of things in the real practice. It's a lot of things. It's the health insurance, like you are doing, Gregory. So it's very important to think about a lot of aspects. People are not so optimistic. They are business people, I mean medical doctors. So you have to be clever and wise how to do that.
Yeah, thank you very much. Maybe thank you for the transition, because you can also underline the transhumanistic vision and not humanistic vision, and we have maybe to improve the quality of the humanistic vision. That's why for the next session it will be Professor Linda Powell from Rush University, Chicago. She's one of the famous behavioral researcher in the world, especially for obesity, but she had a lot of things to share to you. So thank you to be here à 11h15, je crois. See you. Thank you very much.
Thank you very much. Thank you.